All right, let's live on the wild side today and consider something that is quote unquote blasphemous if you speak to a conventional medical doctor or follow conventional wisdom. And that would be the consideration of could high total cholesterol and or high LDL, also known as low density lipoprotein cholesterol, be protective? Now, this is um, countercultural because the dogma is that high cholesterol and high LDL are dangerous and will kill you. As you can see in the upper left there, I made that chart that said your risk of death goes up with the increase in cholesterol. That's what you're taught. And at your doctor's office, if you have high cholesterol, you're more or less strong-armed into taking a statin drug because if you don't, you'll die. The problem with that is that there's been 35 years of statin drug use, and there's no reduction in deaths from cardiovascular disease or stroke. There's just a reduction of cholesterol in the dead people. And so if reducing cholesterol was lowering cardiovascular disease risk, we'd have less deaths, and that's not what we see. So that cholesterol hypothesis, the heart cholesterol hypothesis, is unproven. And so today we're going to consider research that suggests that perhaps the high cholesterol and high LDL are protective, and they're elevated because they're trying to protect you from infection or cancer or something that could kill you. So we are going to slay some sacred cows today. And to do that, we need to switch over to the research. So let's go. And here we are with the research, and this is a paper from the Annals of Clinical and Laboratory Science in 2019. And it's a review entitled Chemical Pathology of Homocysteine 7, Cholesterol, Thioretinaco-Ozonide, Mitochondrial Dysfunction, and Prevention of Mortality. Now don't worry about all those big words. We're going to get to the meat of it right here. So we'll start at the top. The purpose of this review is to elucidate how low blood cholesterol promotes mitochondrial dysfunction and death. Okay, so that first red line you see should cause some cognitive dissonance. What? Low cholesterol promotes mitochondrial dysfunction and death? I was told high cholesterol does that, and I want low cholesterol to live. Okay, well, maybe not. Again, let's push back. Let's challenge some sacred cows here. And before we go any further, I'll remind you that in last week's video, we discussed mitochondrial dysfunction and how if your mitochondria are dysfunctional and unhealthy, then your T cells, your immune system, doesn't function efficiently, and you're at increased risk of cancer, autoimmune disease, poor wound healing, et cetera, et cetera. Remember that mitochondria are the powerhouses of our cells. They make the energy that our cells require to do their jobs. So if we have mitochondrial dysfunction, we have poor energy production, inefficient cells, increased risk of disability and death. So right here, first line says they're trying to elucidate how could low cholesterol in the blood promote mitochondrial dysfunction and increase death. And so if we finish the rest of the sentence, it says that can be promoted by the loss of this thing called thioretinaco-ozonide from opening the mitochondrial permeability transition pore, or MPTP. Now that's a bunch of nerdy stuff that we'll just touch on a little bit. We're not going to dive into that too much, but essentially it'll make a little more sense as we go. Mortality or death from infections and cancer are both inversely associated with blood cholesterol. What does that mean? All right, let me show you in a picture. So if this is that's a poor drawing. Let me try again. So straight down, straight across. Okay. So a linear relationship would be this one. Okay. As the y-axis increases, the x-axis increases. That is a one-to-one improvement or increase. Now, if we talk about an inverse relationship, that looks like this. As y goes down, x goes up. Okay. And so right here it says mortality from infection and cancer are both inversely associated with blood cholesterol. Meaning, if you put blood cholesterol on this end, and you put infection or cancer death risk on the y-axis, as cholesterol goes up, okay, hold on, let me see. Mortality from infection and cancer are inversely associated with blood cholesterol. Yes, so higher cholesterol, lower death from infection and cancer, okay, which is counterintuitive to what you would probably think, okay. Inverse relationship. So as the blood cholesterol goes up, you have less risk of death from infection or cancer. As the blood cholesterol goes down, you'd have more risk of death from infection and cancer. And as the authors say here, you can see this has been determined by multiple cohort studies over 30 years previous to this study, which was in 2019. So in the last 30 years, there's been papers showing that, again, the lower your cholesterol, the higher the risk of death from infection and cancer. And yet we continue as a society to tell you, or as a healthcare system to tell you, lower your cholesterol, lower your cholesterol, lower your cholesterol. Moreover, low density lipoprotein, or LDL, is inversely related to all-cause mortality and cardiovascular mortality. What? My doctor said I need a statin to lower my LDL because my LDL is high. And if I keep it high, I'll be at a greater risk of death from cardiovascular disease. Again, low LDL is inversely related to all-cause mortality and cardiovascular risk. So that's opposite of what your doctor is telling you. LDL, so how might high LDL and high cholesterol be protective from infection? How would it protect you from infection? By this. LDL cholesterol adheres or binds to and inactivates most microorganisms and their toxins. Okay, so if you have an infection, you've got a microorganism inside you spreading infection and releasing toxins, causing inflammation and damage in your body. Cholesterol and or LDL will go up to bind them and their toxins, thereby protecting you and your tissues. Okay, so that would be an intelligent adaptation to the infection. Okay, if your doctor sees a high LDL, they reflexively say you need a statin to lower your LDL. What they should do is say, I wonder if you've got a hidden or stealth infection going on. Could this increase in LDL and cholesterol be protective? And do we want to just arbitrarily knock it down because it's above a number that we don't like? Okay, so again, people are dying at the same rate of heart disease and stroke just with lower cholesterol. Maybe knocking it down arbitrarily is not a good idea. As the LDL binds those microorganisms and toxins, if you don't take care of the toxins and the microorganism, if you leave the infection, right, it makes sense that over time you would continue to have high LDL because the LDL wants to continue to bind that infection and those toxins. Well, if you leave that over time, that might obstruct your blood vessels and drive atherosclerotic plaques. If that happens, then potentially you could have cardiovascular outcomes from that. But again, the cause is the infection being allowed to persist. The LDL and cholesterol were doing their job correctly, right? The human being didn't find and eliminate the infection. Excuse me. The active site of, okay, so here's a bunch of science we don't need to get into right now. All right, so where the mitochondrial dysfunction plays in though is loss of the active site complex from mitochondria results from the opening of the MPTP pore. So up here we said that's the mitochondrial permeability transition pore. If we lose cholesterol, that pore opens. So cholesterol blocks that pore. We want to keep that pore blocked because if that opens, there's a loss of ATP production and that causes mitochondrial dysfunction, which can be observed in cancer, atherosclerosis, aging, and dementia. Again, cholesterol inhibits opening of that pore, blocks that pore. This inhibition or the blockage of this pore explains how elevated LDL reduces mitochondrial dysfunction by preventing loss of the active site from the mitochondria. So again, the LDL binds the infection and its toxins, protecting you that way. The cholesterol blocks the opening of the MPTP pore, which prevents mitochondrial dysfunction, which also protects you because, as we've talked about, mitochondrial dysfunction is a lowest common denominator in chronic disease, as this paper says here, ranging from cancer to heart disease to aging to dementia. So that is very important and very interesting. Let's look down here and say, is there evidence of infection driving cardiovascular disease? Right here in yellow. Abundant evidence from the literature implicates infection by a variety of pathogenic microbes in the pathogenesis of atherosclerosis. Pathogenic microbes and their toxins are inactivated by complexing with LDL. So the LDL binds them and inactivates them so they don't hurt you. This results in a microbe lipid protein aggregate, which, if it builds up, could obstruct blood vessels and lead to blood vessel damage, again, because the infection's left to run rampant, not because the LDL and cholesterol necessarily are evil and damaging you for no reason. They're doing their job, working to clear the infection. So it's the infection, go find it and clear it. The complex formation and aggregation of LDL in the microbes may be enhanced if you have high homocysteine, which we've talked about in the past. Homocysteine damages blood vessels, brain, kidneys, etc. These pathogenic processes lead to inflammation, oxidized LDL, and microabscesses in the blood vessels. Low blood levels of LDL impair the innate immune system by decreasing the formation of the microbe LDL binding, thereby increasing susceptibility to the pathogenic infection, which contributes to pathogenic atherosclerosis. So again, if we're going in a linear fashion, it's the microbe that isn't caught or cleared that's allowed to persist, which then is bound up by LDL and continues to persist. So more LDL is binding more, and that could potentially damage the vessel. And you could go a step backward and say, if you're on a lipid lowering medication, lowering the LDL with the statin may allow the infection to persist because there isn't enough LDL there to bind it up in the first place, and you get in this vicious cycle here. So that's one paper looking at it. Okay. Another one here. We've talked about this in multiple videos, but here's a paper from 2019 that looked at total cholesterol in almost 13 million adults. And again, we are taught that the chart looks like this. The higher your cholesterol goes, the higher your risk of death. And so this paper was looking to see, is that true? Is that what we find when we're studying 13 million people and we're not necessarily being funded by a pharmaceutical company? You can see here, the total cholesterol had a U-curve shape with death in each age sex group having a U-shaped curve. So what's that look like? If we go down to the pictures here, what they did is they took, I'll make it bigger. They took adults they grouped the youngest group 18 to 34 in one group, but from there they went 10 years, so 35 to 44, 45 to 54, 55 to 64. And the blue is men, the red is women. And they mapped cholesterol level and risk of death. And as you can see here, they're all U-shaped, okay? Whatever age you're at is U-shaped. So this communication that they've been giving our society is not true by the science. The science says U-shape. And if there's a U-shape, that means there's an optimal level, okay? And on either side of that optimal level, there's a too high and a too low. So it is possible to go too high and that be disadvantageous. But if you'll notice here, if we clear all these out, let me get a color that's maybe easier to see. If you pay attention to the charts, except for the youngest age group, it's more dangerous to have a lower cholesterol compared to a higher cholesterol in each group. Okay, so the lower you go, the higher your risk of death from all causes, no matter what age you are once you're 35 plus. So our society, our healthcare system's telling you it's too high, lower it. And if you ask them, well, doc, what's the goal here? Right? Ask yourself this question. If you're watching this and you're on a statin drug, has the doctor that puts you on that medication ever told you, here's what we're shooting for? We want to get you down to this number and then stop. If you have had that conversation, please reach out to me because I've never met someone who has. And another way to look at it is I've had patients go to their statin prescribing physician and say, doc, what's our goal? Do we want my cholesterol to be zero? Right? And then I wish I could be a fly on the wall to hear the responses, because that thought has probably never crossed their mind. Well, there is going to be too low of a level of cholesterol because cholesterol is required for health. Well, the research here is showing that optimal, okay, the optimal level across all age groups, this paper says, falls between, right here you can see it, falls between 210 and 249, okay? Well, on every lab test in America, the total cholesterol normal range says it wants you below 200. Okay, so automatically, and if you're above 200, if you walked in and you had a 210, your doctor's going to say that's lab high, and the lab will mark it lab high. And so you're probably not far from a statin conversation. You'll definitely have the statin conversation if you're 249. Okay, so here's an example of where the research doesn't match up with the way it's practiced clinically. And in this case, the way it's being practiced clinically is increasing your risk of death from all causes. So going on a statin drug because your total cholesterol is at 210 is not a good idea. All right, based on the research. If we go back to our U-shaped charts, look at where, look at where it really takes off. If you're a male, age 35 to 44, and your cholesterol drops below 175, all right, you're skyrocketing your risk of death from all causes. That's infection, that's cancer, that's diabetes, whatever. If you're a postmenopausal female, okay, the numbers on postmenopausal female is the lower you go below 180, the higher your risk of death from all causes. The lower you go below 150, the higher your risk of death, specifically of type 2 diabetes and breast cancer. So again, it's U-shaped and it's much more dangerous to be too low than too high. So that sacred cow needs to be slaughtered. We all have to be having a sacred cow burger tonight. Okay, and if you weren't convinced by this, here's one more study I want to show you. Paper shows us total cholesterol levels mapped against mortality for 164 different countries. Okay, so on the y-axis here, you can see all-cause mortality. And this is from WHO data. And on the x-axis, you can see average cholesterol for men from a heart study here. Okay, and so cholesterol, this study found that cholesterol between 200 and 240 showed the lowest all-cause mortality. So basically the sweet spot here, the sweet spot in this study was similar to the study I just showed you of 13 million people, and it falls in that 220 to 240 area. 220 to 230 looks pretty good. Okay, that's safest. So if you go below that, because that would be lab high in your doctor's office, you're increasing your risk of death the lower you go below that. And you can see here, the lower the cholesterol, the more infection and parasitic diseases and possibly higher cardiovascular disease they saw. And this is worldwide. Okay, each of these dots is a different country. For example, right here, let's see a country that one of us that we know. Here's Turkey, their average cholesterol and death rate. Here's Bangladesh. Let's see, here's Colombia, here's Germany. So the way you read this chart is each of those dots is a different country, one of 164 countries they mapped against. The blue line is all-cause mortality. for all the countries. Okay, the green line is communicable diseases risk. The red line is non-communicable disease risk. So things like heart disease, diabetes, cancer, etc. So again, there's been multiple studies done showing that the sacred cow, as it's marketed, is not actually what bears out in the research. And so if you're making your medication decisions based on false data, you're going to fall with the crowd where they fall, and that the crowd falls into the group that dies at the same rate of heart disease and stroke, just with lower cholesterol. Well, maybe they're dying at that same rate because lowering the cholesterol increases the risk of death because it's preventing their immune system from properly responding to infection and cancer, and it's driving mitochondrial dysfunction. So let's address one key question that will probably come up. Okay, so here's a paper that high cholesterol may protect against infection and atherosclerosis. So again, here's a paper looking at questioning the sacred cow. And one question that may come up here, he addressed in the his conclusions here is the fact that high cholesterol predicts coronary heart disease in young and middle-aged men, okay, which is what we saw over here. The 34 and under is the only age group where the U shape isn't quite U-shaped. It almost fits what they say, mainstream wise. Okay. The fact that high cholesterol predicts heart disease in young and middle-aged men would seem to argue against any protective role for high cholesterol. However, high cholesterol may reflect the presence of factors promoting heart disease, which may outweigh the beneficial effects. As most men of middle age are in the midst of their professional career, high cholesterol may reflect their mental stress, a well-known cause of high cholesterol, and also a significant risk factor for heart disease. Thus, high cholesterol may be a risk marker for high stress, not a true cause. In other words, what he's saying is, and this paper was published, 16 years after he published this paper, but we have a picture right here that helps us explain what he's saying. He's saying this isn't U-shaped, but the high cholesterol may not be the cause of their increased risk of death at this age. It might be a sign of actions that lead to increased risk of death, like the stress associated with their career. And high mental stress will raise cholesterol. It's not the cholesterol that killed them, it was the high mental stress. The cholesterol was, say, the canary in the coal mine, or the symptom. And that brings us back to, okay, if we question this, if we're having that cognitive dissonance and we don't want to be blasphemous and kill that cow, well, all these studies, they say that high cholesterol, high LDL heart disease, again, well, why is it high? If the cholesterol and the LDL is doing its job to try and bind up the toxins from the infection, then again, it was the canary in the coal mine. It wasn't the cause, it was trying to save you. So this paper we started with ends with, this analysis attributes the increased death from infections, cancer, heart disease, and diseases of aging to low total cholesterol and LDL levels associated with the mitochondrial dysfunction and the opening of the MPTP pores by deficient concentrations of the cholesterol. So again, this analysis attributes the increased death rate from all those different things to the mitochondrial dysfunction that's caused by having low LDL. Okay. So what we want is not too low LDL or cholesterol and not too high LDL or cholesterol, but of the two, it's safer to have a little bit higher versus a little bit lower. And so hopefully this got you thinking and stimulates some good conversations with other practitioners, and maybe you provide them with these studies to help offset the cognitive dissonance that's going to come along with the conversation. And perhaps this will help you speak to them about, okay, doc, before I consider a statin medication, should we rule out a stealth infection? Should we rule out cancer if that's in the family history? Should we rule out one of these other drivers of inflammation which promote increased cholesterol versus just pinching the canary's beak and continuing to walk into the coal mine and die of carbon monoxide poisoning, which the canary was trying to warn us about, metaphorically. So have that conversation, question, why is it high? And also, lastly, is it truly high? Because again, based on the research, your 210 to 249 isn't actually high. That just looks high because the lab's normal range is too low. And that's influenced by Big Pharma and statins being the best-selling class of drugs of all time.
I would like to say that I had read an article or listened to somebody speak about cholesterol as well, that when your diet has a lot of sugar in it, it does a lot of damage, and the cholesterol is actually trying to repair the damage.
Yeah, yeah, absolutely. I've described it as, um, if you have a party in college and you invite your friends over, there's always that one friend who's just a drunk idiot, and you're like, should we invite him? No, but we have to, and he gets drunk and he punches holes in your drywall. And the next day the party's over and the holes are in the drywall, and you have to call the handyman to come back and patch the drywall. And then next week you throw a party and you invite that idiot over again, punches hole in the drywall. You got to come out of pocket, pay the handyman again the next morning. The LDL is the handyman. Okay. The LDL is coming to patch holes in the drywall. If you don't want to keep elevating the LDL every week, stop inviting the idiot who punches the holes. Right. So metaphorically, that quote unquote idiot punching the holes is high homocysteine or infection or the sugar, as you were talking about, Kim. There's various things that promote vascular damage. And so rather than tackling the handyman and putting him in handcuffs with the statin drug, why don't we tackle whatever's punching the holes in the drywall, tackle the sugar in the diet, or tackle the high homocysteine, or tackle the infection, right? So another way to look at it is as exports and imports. So LDL in common vernacular is called the bad cholesterol, and HDL the good cholesterol. Well, there's no good and bad. LDL is the exporter. It takes cholesterol from the liver and goes out to the periphery to patch drywall. Okay, HDL is the importer. It takes cholesterol from the periphery back to the liver to be broken down or metabolized. So again, it's not that we need to smash down LDL and raise HDL. It's, hey, we've got an imbalance in imports and exports, favoring exports right now or favoring high LDL. Well, why? What's driving that perceived imbalance? And figure that out. In this case, eliminate the high sugar consumption. Now you're not punching holes in drywall. Now you don't need so many handymen out there. What else?
I've also, my understanding is the statin drugs lowering your cholesterol also does damage to your mind, because as you
Oh
get
yeah.
older, you need more cholesterol for your brain as you grow older.
Yeah, the brain is 60% fat, and so there's a lot of cholesterol in there. And we've talked about in previous videos that, yes, statin drugs. So in cholesterol synthesis, there's 32 steps. Okay, and statin drugs block it at step number 3, which is called HMG-CoA reductase. And those drugs are statin drugs are literally HMG-CoA reductase inhibitors. Okay, so if you block the production of cholesterol at step 3, well, down here we need cholesterol to make testosterone, and we need it to make estrogen, and we need it for vitamin D physiology, and we need it for all kinds of things. And so you could have hormone issues with statin drugs. You could have inflammation and immune imbalance and D issues. Many people, like you said, have brain fog, short-term memory loss. Well, one reason for that is statin drugs are known to cause deficiency in coenzyme Q10. Well, coenzyme Q10, if I switch papers here real quick, coenzyme Q10 is required for mitochondrial health. So if you've got deficiency in coenzyme Q10, you drive mitochondrial dysfunction. And all cells have mitochondria, just about all cells. The brain has tons of them, the heart has tons of them, muscles have tons of them. So if your mitochondria aren't working well due to a CoQ10 deficiency, which is required to make the energy for your cells to work well, then you may have the muscle pain symptom that often comes with statins. You might have the brain fog or the transient global amnesia, which is a neurologic symptom of statins. You might have cardiorespiratory symptoms because the mitochondria in the heart become dysfunctional. So yes, CoQ10 is huge, and it's driven by statins, and so it's a major reason why statins can have such broad symptoms with them is the CoQ10 deficiency, and also the fact that they're blocking cholesterol synthesis at step 3 out of a 32-step process.
Okay, since we're going towards holy cows or whatever you want to call them, don't the doctors get trained in this when they're going through school? Or are they having a lack of training of something so that they believe that this is doing you
it's both. It's both. They're trained that pharmaceuticals are the answer, and they're not trained at all or beyond like an hour or so of nutrition. So they have no idea about nutrition and how nutrition plays into physiology, and they're taught that drugs are the answer. And if everything's a nail, you're a hammer. Drugs are the hammer. So medical schools are subsidized by pharmaceutical companies. Medical textbooks are subsidized by pharmaceutical companies. Medical journals are subsidized by pharmaceutical companies. They wouldn't survive without the ad spend by pharma. So yeah, it's a problem in the system and even in chiropractic school where I went, we had more nutrition training than medical doctors do, but still it's not enough to put this video together. You have to go above and beyond and have to learn it. So yeah, the system's broken because it's very biased towards pharmacy. And many medications are mitochondrial toxic and drive mitochondrial dysfunction, not just statins. There's tons and tons of them that are. So, the treatment that they are giving for a vast range of disorders that are common in the US all drive mitochondrial dysfunction, which is, contributory to all the chronic disease. So it's like, are we helping the patient or not? And then you all are aware of the fact that if you stack more medications, the more medications you're taking, the more side effects you have. And now you're on medications for medications. And yeah, it goes downhill quick.
They gave my dad a statin drug for fatty liver, which I had never heard of that before.
Mm-hmm. Yeah, so the liver is kind of where the imports and exports. The liver would be the I'm trying to think of the right word, the port where the imports and export ships are coming to do their work, I guess. And so in the liver, the LDL receptor is the liver and is driving LDL receptor function, and the LDL receptor is determining, hey, are we sending LDL out or bringing it back? And so they're probably trying to impact his fatty liver that way by impacting the LDL receptor with statin drugs, or attempting to.
Yeah, he's never had high cholesterol. And he says he feels worse since he started taking that medicine. He was trying to find something else, but he's on several other pills. And I don't know.
Yeah, without knowing his case, it could be a million things. The first thing I would look at is he a drinker?
Yes.
Okay, so you could have, so is it alcoholic fatty liver? Have they diagnosed it as that?
No, I think it was not. It was non-alcoholic fatty liver, but I'm not positive about that because he doesn't ask questions, so he wasn't sure.
Okay, so let's just, for the purpose of conversation, say it's not alcohol. If it is alcohol, then obviously, you need to work on that. But
Right.
Non-alcoholic fatty liver is basically, fatty liver for any reason other than alcohol. But a very, very common reason would be insulin resistance or blood sugar issues. So then the next place to look, if he's not a heavy drinker would be, okay, how's his blood sugar handling from both the sugar side and the insulin side? And I made a video today that I haven't published yet, but I will soon, looking at a patient who's, medicine. To Kim's question, why aren't they trained in this? Here's another thing they should be trained in and do better, Kim, is in regards to testing blood sugar regulation. Medicine only looks at the sugar side, right? You go and you get your yearly physical and you have your fasting glucose run, and they run your hemoglobin A1C, which is your average blood sugar over the last 90 days, right? Well, where's the insulin markers? The insulin's the other half of the equation. They never run those. And so in the video I made today and haven't published yet, that I'm dealing with a guy with seizures, 69-year-old with seizures, and they're non-epileptic, so they've run EEGs on him and his brain's great. There's no electrical issue with his brain. Okay, but they have no answer for him. You have non-epileptic seizures, see ya. And I said, okay, great. They ruled out the neurochemistry or the electrical side to the brain, but they haven't ruled out the metabolic side. So his A1C, which is his average blood sugar over the last 90 days, was a 5.6%, which is in normal range, but it's functionally high from my perspective. Okay, so the doctor would see that and say, your blood sugar is normal, you don't have to worry about it. They don't look at insulin. I look at insulin. His serum insulin was lab high at 27.9. Ideal would be less than 5. His C-peptide, which is his average insulin over the last 90 days, is lab high at 4.4. Ideal is like 1.2. So he's clearly insulin resistant. But because they only look at half the equation, they tell him his blood sugar is fine. Well, if you're that insulin resistant, that's going to drive non-alcoholic fatty liver. Guess what? His ALT is lab high, which is one of his liver enzymes. Okay. So again, I would look at your dad's blood sugar stuff, and by that I mean look at his blood sugar and his insulin markers, or else he might fall into the problem that this gentleman did as well. And so check his blood sugar and insulin.
Okay, thank you.
Mm-hmm.
So
Kind of
what should,
Sorry, one more thing. I was kind of off topic, but not, because that metabolic dysfunction will drive cardiovascular disease. Insulin resistance, type 2 diabetes, cardiovascular disease, they're all in the same boat. So it's called metabolic syndrome, or could develop into that. So you want to check that out. Okay, go ahead, Niraj.
I just wanted to continue with that patient.
Okay.
Sugar level is not high, insulin resistance is high.
Mm-hmm.
In my linear thinking, the way to increase insulin resistance or decrease insulin resistance was to cut down on sugar. But this guy seems to be already not taking enough sugar, so what should he do?
Yeah, great question. So go ahead and mute yourself, please, just because of the background noise. Thank you. So Niraj said, okay, the example I just gave you is insulin resistant, but his blood sugar wasn't high. So the first thought with insulin resistance is to reduce blood sugar, Niraj said, but if it's not high already, then what do you do? Well, it was functionally high, so it does need to come down. But if we just treat it as not high, we have to expand our understanding of what impacts insulin sensitivity. So if you're not insulin sensitive, you're insulin resistant. Okay, so we want to be insulin sensitive. We want to hear the knock at the door when insulin knocks to deliver the blood sugar. So if his blood sugar is not high and we want to lower insulin, you can still do that with diet. Okay, and if he's a drinker, he's drinking sugar. Alcohol is metabolized to sugar, so that needs to be dealt with. And then anything else, too much sugar wise needs to be investigated in that diet. But let's say his diet was dialed in. Well, now what do we do? How do we promote insulin sensitivity otherwise? Lots of ways. Physical activity is a big time contributor to insulin sensitivity. If you're sedentary and physically inactive, you're not driving cardiovascular health, you're not driving muscle health. And so both aerobic exercise and weight training and skeletal muscle building improve insulin sensitivity and optimize blood sugar. So looking at his physical activity levels is one place to win. Another place to win would be sleep quality, quantity, and timing. Sleep deprivation interrupts your insulin sensitivity and drives insulin resistance, and it doesn't take a lot. There's studies showing that just one night of poor sleep increases inflammation, blunts insulin sensitivity, decreases antiviral defenses. And that's just one night. If you do it lots of nights, days, weeks, months, years in a row, things go downhill quick. So again, sleep, timing, quality, quantity is huge. Stress levels. The more stressed you are, the faster you're heading toward insulin resistance when the stress is chronic, because what is stress? Stress is you running from a tiger. To run from that tiger, you need fuel. Fuel is sugar. Stress will dump sugar in your blood, take it from your liver and your muscles, dump it in the blood so you have fuel to run or fight. So the chronic stress is chronic sugar, okay? And so ultimately that chronic stress drives insulin resistance, because you're continually dumping sugar in the blood, and the body's like, we don't need this, we don't need this. There's no tiger, you're sitting at a desk, what are you doing? Okay. And then toxins can drive insulin insensitivity or insulin resistance as well, in various ways. So it's a whole lifestyle approach to promoting insulin sensitivity. If the diet's dialed in, that's great, but that's only 1/5 or 1/6 of the equation.
Awesome. Thank you.
Dr. Bartemus, let's say, both Jeff and I are in our 80s, and we've been obviously at this stage on statins for a long time, numerous years. So in order to maybe start the idea of a conversation, would I ask to lower the dose? For instance, I'm on, 20 milligrams or whatever that dose is. Would I request to get 10, which I think is the lowest that they usually give? I don't know, but there might be something lower. So would I start by asking for that and see how that,
you could, you're likely to run into a brick wall
Yeah.
with that, but may I share some data on you
okay,
to answer your question?
share some data on me. Go ahead.
Okay, so your total cholesterol when we ran it, okay, let's do it like this. Your total cholesterol when we ran it was 118. Okay,
Okay,
you're in this age range.
right.
118 is right here.
Boy, that sounds wonderful, according to the doctor.
Yeah, exactly, right? But based on the chart, it's not. Okay. Your LDL was 27, which we don't have a chart on here for LDL, but 27 is very low. The quote unquote, normal range, they don't want you above 110 or 120, depending on the lab you use.
Mhm.
And again, they have no bottom, but we don't want 0, and 27 is pretty close to 0. Optimal, they say, is like under 100. So you'd rather be up in that 90-ish range in my thinking. But if we just use your total cholesterol at 118, again, you want to go ask, you could bring this paper in and say, here's where I fall in the age range, here's where I fall in my total cholesterol. What is our goal here?
Yeah, okay.
Right. And that's, this is the way to do it with data, and it gives you the best shot at, hopefully they have a conversation. Maybe you send them this ahead of time and say, would you mind reading this? Because I want to discuss this, and that way they don't get pinned, unexpectedly. But yeah, it's with the information we have, it's a conversation that should be had.
Okay.
And then I've made videos on this in the past, and I talked about this earlier. The CoQ10 deficiency is one thing to consider, but in other papers or other videos I've made, selenium is an issue, can be an issue. Vitamin K can be an issue. Glutathione can be an issue with long-term statin use. So again, selenium's needed for antiviral defenses, for thyroid physiology, for all kinds of things. Glutathione is your body's master antioxidant, needed for antiviral defenses. vitamin K, blood clotting, prevention of calcium deposition in the arteries, all kinds of things. So, again, sometimes people need medications long term, but it's easier to take them if you've discussed with the doctor, okay, I'm taking this for what reason and what's our goal here? Like, what's our goal ceiling and floor wise? Like, what's the lowest we want to go? What's the highest we want to go, depending on what drug you're using and stuff. And that way, if you both have defined targets, you can follow it and decide when and if a dose needs to be changed or you need to come off or that sort of thing.
Okay, so if some blood tests are showing off and on high triglycerides, that means too much blood sugar, or that could be from the night before.
Good question. So
Yeah.
if you're fasted and they're high, then they're high. If you're not fasted and they're high, we can't trust them because you ate recently. So what you ate recently could skew them. So if you're fasted and your cholesterol panel is good, but your triglycerides are high, that's more related to blood sugar and insulin handling. Yeah.
Okay.